Endometrial carcinoma. This is a malignant tumor arising from the endometrial lining of the uterus. It is the most common gynecological cancer in the developed countries. Unopposed estrogen exposure. Major risk factor. Obesity, peripheral conversion of the androgen to the estrogen, polycystic ovary disease, estrogen secreting tumors, granulosa cell tumor, hormone replacement therapy without the progesterone. Reproductive factors like nulliparity, never having given birth, early menarche, late menopause, longer estrogen exposure, genetic disorders like Lynch syndrome, hereditary non-polyposis colorectal cancer, metabolic disorders like diabetes mellitus, hypertension. Types of endometrial carcinoma. Type 1. Endometrioid adenocarcinoma, estrogen dependent. Most common 80 to 90%. Associated with the hyperplasia and unopposed estrogen. Generally low grade, slow growing and the good prognosis. Type 2. Serous, clear cell and other non-endometrial types, estrogen independent. Less common but more aggressive. Not linked to the estrogen exposure. Occurs in the older women, often with the atrophic endometrium. Poor prognosis and the early metastasis. Pathophysiology. Type 1. Endometrial hyperplasia progresses to the dysplasia and the carcinoma. Type 1 arises de novo from the atrophic endometrium without the precursor lesions. Postmenopausal bleeding. Most common symptom. Menorrhagia or the intermenstrual bleeding in the premenopausal women. Pelvic pain or pressure in the advanced cases. Weight loss, anorexia, fatigue in the late stage disease. Diagnosis. Endometrial biopsy. Gold standard. Confirms the diagnosis. Transvaginal ultrasound. Evaluates the endometrial thickness greater than 4 mm in the postmenopausal women is concerning. Hysteroscopy with directed biopsy. Used if a biopsy is inclusive. MRI CT scan for staging and the metastasis evaluation. FIGO staging. Staging 1. Confined to the uterus. Stage 2. Involves to the cervix. Stage 3. Local spread to the pelvis, lymph nodes. Stage 4. Distant metastasis, lungs, liver and bone. Treatment. Stage 1. Total hysterectomy with a bilateral salpingo-oophorectomy, TH&BSO, lymphadenectomy. Stage 2. Radical hysterectomy plus lymph node dissection and the radiation. Stage 3-4. Chemotherapy, paclitaxel, carboplatin, radiotherapy for local control. Hormonal therapy, progestin, tamoxifen, aromatase inhibitors in the hormone receptor positive tumor. Targeted therapy for advanced cases. Pembrolizumab, PD-1 inhibitor for MSI, Lynch syndrome associated cancer. Prognosis. Type 1 has a good prognosis, 90%, 5 years survival in the early stage. Type 2 has a poor prognosis due to the early metastasis. Endometrial carcinoma. This is the most common gynecologic malignancy in the developed countries. Unexposed estrogen exposure is the strongest risk factor. Postmenopausal bleeding is the most common presenting symptom. Type 1 endometrioid is estrogen dependent, while type 2 is serous, clear cell is estrogen independent. Endometrial biopsy is a gold standard for the diagnosis. Transvaginal ultrasound showing the endometrial thickness greater than 4 mm in the postmenopausal women. This is suspicious. FIGO staging determines the extent of the disease spread. Total hysterectomy with a bilateral salpingo-oophorectomy. This is a mainstay treatment for the early stages. Advanced cases requires the chemotherapy, paclitaxel, carboplatin and or the radiotherapy. Hormonal therapy, progestin, tamoxifen is used in the hormone receptor positive cases. Lynch syndrome increases the risk of endometrial and the colorectal cancer. Poor prognostic factors include the high grade tumors, deep myometrial infection and the lymph node metastasis.